Okay, so at this virtual journal club, we decided to look at 3 different papers, and they all pretty much deal with hyperlactatemia. And I divided the papers up per 2 interns, and I think I did that because in case not all of us could be here, which is currently the case. I think we'll start with the one about cats. Who had the cat one?
I think me and Perry.
Yeah.
All right, so the format that we used before, and the both of you were indisposed when we did the first one. Did you have a chance to look at the video from that?
No, I forgot, actually.
All right, so
I spoke with Tim about that. We went over this morning the video from previous.
All right, cool. So we kind of following that format. We're exploring this method for doing journal club and following that format because the objective here is to learn how to look at a paper and decide if it's relevant, and also to be able to look at some of the results and make a decision about whether or not we're going to apply it to our practice, and be able to continue learning from the literature even after we do internships or residencies or whatever, because you all can be going into residencies or private practices or whatever, and you need to be able to stay current. I personally found it quite challenging when I was a general practitioner and had not had any formal training. I found it very challenging to decide what was good and what was bad, and not necessarily bad, but maybe not useful. And I was hoping that we could kind of develop a system that would serve you well after you're out of your internship. So the first paper is both of these are in 2015, and they're JAVMA papers. The first 2 are. The third one is a human paper. And we're talking, it's Erica Runke et al. With the Association of Blood Lactate Concentrations with Physical Perfusion Variables in Cats Treated at an Emergency Service. So what did you guys think about the abstract part? Or just start. You can just go ahead and start. I'm not going to dictate how you evaluate it. Why don't you tell me what you think?
So just using the PICO.
PICO.
So they had a population of 111 cats from the University of Pennsylvania Emergency Service. As far as the intervention, that one I was unsure of how on this one, because I believe it was just these cats that came on emergency for a wide variety of reasons. Control comparison. So they were looking at blood lactates and the systolic arterial pressure coupled with a clinician's physical exam findings, so TPRs, just well as the clinician's experience to determine was the patient shocky or not. And then the overall outcome, so blood lactate may be useful when assessing patient's state of shock, but it doesn't really give an overall prognostic indicator for outcome, just because, as we'll find out, some cats had a high lactate but were not in a state of shock, and vice versa. So it's something that I think they're trying to get across can be a tool, but you have to look at the overall patient status and other parameters.
Excellent. I agree with that completely. What did you look at next after you did your PICO statement?
So that would be just kind of going through the charts that they had. There's a couple of box and whiskers plots, kind of comparing lactates. Then I guess on the page 83, I think was the best box and whisker plot, or to me made the most sense as far as comparing lactates on the y-axis, and then on the x-axis having the 3 categories of no shock, mild to moderate shock, and then severe shock. And you can see just from that one the overlap, as we talked about, for some patients were deemed in one of these categories, but you see there's a wide range of overlap as far as the lactates are concerned.
Exactly. Did you all look at the SPI2? Did you look at what that was when they talked about classifying their shock? Isn't this a study that used the Survival Prediction Index too?
Is that on a...
Isn't this the study that did that? Hold on a second. Am I getting them mixed up? Yeah, I think this was the one.
The one that you're talking about for as far as qualification, like looking at the what parameters they use to determine like the systolic arterial pressure. Is that what you're talking about?
Wait a second. I may have gotten my studies mixed up. I apologize. Let's just move forward and we'll get to that in a minute. I'd like to make a comment about the whisker plot box. That was kind of a cool graph, and I really super appreciated on page 82, the very first one. I think they actually tell you and explain to you what they are. If you look at the legend under that first box, it explains the top of the box represents the first quartile, the bottom of the box represents the third, and the horizontal line shows the median. I, for one, really wasn't very familiar with these cute little box and whisker plots, and I really appreciated that the authors put an explanation in. You don't see that very often, but at least I don't, and they put an explanation of actually how to interpret the graph, and I thought that's really cool. So I actually made a little note of what they mean, because that's new information for me, so that when I see these, and I think it's a cute name too, box and whisker plot. I don't know who came up with that, but I think that's really cute, and I found that extremely useful, and I really appreciated the authors doing that. The other thing, if I can just make a comment, do I have another thing? The other thing is under Table 1, you didn't really talk about Table 1 very much. I found it was really interesting. If you looked at the p-value on the right-hand side, you know, they say, quote unquote, statistical significance is less than 0.05, right? So if you look at these variables that they looked at and the way they correlated with lactate, for example, heartbeat didn't really do anything, and then the capillary refill time didn't. So I found it really interesting looking at the p-values for the various parameters and how they coordinated with the lactate levels. And there were a few of them that were statistically significant, but there were also a few of them that weren't. You see that, you guys? Okay. Do you have any other comments to make?
So as far as I guess the next thing is looking at bias. There's a couple that they outlined specifically. So on page 83, it talks about that there's see the last paragraph there. So you have let's see, 10 hyperlactatemia cats in the study were included in the no-shot category because they were classified as having normal perfusion greater than 90 millimeters of mercury. And then they go on to say that it's important to note that the other causes of hyperlactemia were not evaluated for, other causes outside of shock, so such as hepatic dysfunction, hypoxia, and neoplasia. And then another one that they talk about is blood draw technique. So the idea of holding off for a long time, kind of, how long did it take to get the sample into the machine and so forth. But interesting, they quote two papers. One paper seems to suggest that there's no correlation with blood draw technique and increased lactate, and then another paper completely contradicting that. So certainly there could be a bias associated with that as well. And then also, I guess you have a number of clinicians, and it talks about their assessment for is the patient in shock or not was based on clinical experience. So in a wide range of what clinical experience is and how long they've been clinicians and so forth. So that in and of itself could also be a bias.
That's a really good job, Chris, because those are the three things that I picked up on myself when talking about bias. I have all three of those areas circled under the discussion. Does anybody have any other comments about this paper? I think they pretty much summed it up at the end of the discussion where they say blood lactate concentration should always be evaluated in the clinical context of the patient. Mm-hmm. You know, one of the reasons I chose lactate as a topic and just these current papers is because we measure that a lot, right? And we always talk in rounds about what their lactate level was. But I don't know if we ever really critically evaluate what that lactate level in that particular animal means. Mm-hmm. And, you know, how significant is it? How insignificant is it? What are the potential causes for the lactate? How worried would she be about it? Where we should put it in the context of our prognostication. So that's the whole reason why I chose this topic for us, because it's something we measure regularly, we report it in rounds, but we never really discuss. I don't know how much thought goes into it, but I always try to think about, oh, okay, he's got an elevated lactate. I wonder why that is. So that's the reason I chose this particular topic, because in terms of being relevant, the topic, because it's something that we measure all the time. But I don't know that we actually say, oh, he's got an elevated lactate. I think that's because we just report it as a finding. And we probably should give a little bit more thought process as to why the lactate's elevated. Any other comments on this?
So, Dr. Braswell, what is your takeaway then? Because kind of the conclusion is use lactate in the face of, or what I'm getting is use lactate in the face of clinical signs, but even then it can be confounding. So, yeah, I always think about, like, for instance, the blood gas machine that we were using and the hematocrit value, which we don't believe is very accurate in and of itself. And so we always say, it seems like very quickly the first thing that I think is, oh, the hematocrit's normal, so therefore it's normal in this patient. But if it's erroneous, I think, well, that could just be the machine. And we
Is the rest of the information correct? Yeah.
Exactly. So how do you weigh out lactate then, as far as not having that inherent bias of, it seems like you could already have one.
Just in the methodology, right?
Exactly.
For the time being, the trend is probably more important than the value itself, once we decide on which one we tend to like the best. So trending, again, tends to be very important. It's kind of like blood pressure in animals, you know, indirect blood pressure, not direct, but indirect. It tends to be more valuable as a trending tool because it's not as exquisite in animals as it is in people. So I tend to think that sometimes we have to recognize there's some limitations in the technology and the methodology that we have, and that sometimes we have to maintain that perspective that a trend is probably more valuable than an actual number. Gotcha. So that's my general answer to your question for this purposes, and we'll discuss the actual equipment that we have later.
Okay.
Okay. So any other comments on this paper? Really good job, you two. Excellent job. That is. How did you feel about looking at the paper that way, Chris, since you didn't have us last time?
Yeah, actually, I was new to especially the PICO idea until Tim explained, but I kind of like it because it makes kind of, I won't say cumbersome, but just scientific papers in general. Sometimes it's hard to sift through, and so kind of breaking apart makes it easier to.
And you know, and you can do it fairly quickly too.
Right.
Like, is it relevant? No. Okay, I'm not going to spend my time on that paper. Okay, it's relevant, but is it useful, or does it look like it's reliable? Oh, then I'm going to take this information and I'm going to incorporate it in my practice, and that's the whole idea. And I found it extremely useful. So good job. All right, let's move on. The next one is also a JAVMA paper published this year, or excuse me, in 2015, survival analysis of critically ill dogs with hypotension with or without hyperlactatemia. This is by Laura Attica et al. And who had this paper? Hi, Keith. Did you have it, Tim?
Yeah.
Okay. Do you want to give us some kind of idea?
Yeah. So going through the PICO population in the study were 67 dogs, presented through University of Pennsylvania emergency, admitted to ICU, and then had their systolic blood pressures and lactate measured. And then kind of ran into the same thing as Chris did with the intervention. I wasn't 100% sure what I was looking at for intervention in this case. It wasn't like...
Yeah, I've got to address that. We'll do that.
Okay. Then control comparison, comparing critically ill dogs, both who had hypotension, but the difference being with or without hyperlactatemia. And then the overall outcome based on this paper was that hypotension with increased lactate had a decreased survivability, survival predictability, I think it was.
Okay.
So then going through the tables and charts and the results.
So I get my studies. Sorry to interrupt. I got my studies mixed up. The survival prediction index was on this study. Sorry about that. Okay, go ahead.
All right. So The first table just kind of gives the variables with and differences between the dogs with elevated lactate versus without, and the more significant things here being the systolic blood pressure, and then I do include the predictability index, and then duration of hospitalization. Thought the duration of hospitalization was kind of interesting, but if you kind of put it in context, the duration was shorter for those more critically ill with hyperlactatemia.
Yeah.
That was more associated with their illness and either euthanasia or death. Second table kind of goes through, again, more variables of, surviving to discharge, what their sort of systolic blood pressures were, and if they fell into that more severe hypotension, and then if sepsis was present. So, kind of looking through there, we had kind of equal amounts with the blood pressure. Dogs with hyperlactemia fell into both categories of with or without severe. The dogs without had a systolic blood pressure greater than 70. So I think that helps too in determining, what's going on with that particular patient. And then the figure 1, the Kaplan-Meier survival curve, just showed again that your hypotensive patients without hyperlactatemia had a better survivability.
Agreed. I agree. Did you find any evidence of bias in this particular paper, potential bias?
I did. I know in the beginning they talked about the type A and type B, and they tried to do what they could to rule that out, but I think in some of them, again, not knowing completely, but I don't think in every patient you could rule out all of these before. If you have hip by car, you can't try and rule out, are they diabetic or Cushionella or something like that. So I think that's certainly there. It would be under bias, but or maybe a degree of bias that it wasn't quite standardized. The treatment protocols, granted it was retrospective, but everything wasn't standardized, and some patients had measurements taken before, during, or after fluid resuscitation. So I think with those in there as well, it's kind of hard to determine. And then they go on and say also in results of, we have respiratory disease, sepsis, GI disease, hepatobiliary, cardiac, kidney, and then undefined. It's like, what is it really causing, the abnormalities that we're seeing?
All right, I agree with that. I found it really interesting under the discussion that they made a comment in the first paragraph that, let's see, additionally, all the dogs were treated in the intensive care unit and were hypotensive, with 85% of them remaining hypotensive and 57% having concurrent hyperlactatemia despite IV fluid therapy. And I'm going, where's the pressors, right?
Right.
All they did actually for their hypotension was fluid therapy. That's the impression I got, right?
Yeah,
so
it seems like
it
did one bolus.
Yeah. And they, the other thing is they talk about down a little bit further, they talk about the findings supporting the concept that hypoperfusion induced anaerobic metabolism causes hyperlactatemia. I think that was a little bit of a reach, that generalized statement. The other comment I'd like to make about this particular paper that I really appreciated that the authors did, just like the other one, was there's a little bit of a paragraph down here talking about when assessing survival curves, they used like 3 different tests, and the first one's the curve, the other one's the middle curve, the other one's the end of the curve. I had no idea that's what those tests did. Make a little note, right? Just like the box and whisker plots. I thought that was really nice. So every once in a while, now that I'm looking at this differently, I'm finding places where authors interject, this is the reason why we do this kind of thing, or this is how you read this kind of graph. So I found that really beneficial, and I appreciated the fact that they did it. Do you have any other comments before I go on, Tim?
Um, Not really. I guess the only one just kind of overall, like with the paper of, using it or not. I think a single lactate is not ideal. I know when we talk about GDV all the time, you could jump the gun and say, your dog's lactate's 12. This is terrible, but then you get them hydrated or fluid resuscitated, and it drops down to maybe 3 or 4 or something like that, and then it continues to improve. So I think, and they mention it too. They're more prospective studies of serial lactates with appropriate treatment.
Yeah, I agree. Trending is important. And it's important. They do, both these papers, I think, mentioned Surviving Sepsis Campaign, and they both mentioned trending lactates in sepsis is really important. And I think that kind of plays out in what we're seeing here. The only other comment I had to make that they make a comment here where they say the inclusion of hyperlactatemia in the definition for septic shock has been debated because it implies poor prognosis. And then they said in a retrospective study of 302 patients with septic shock, yada, yada, yada. I thought 302 patients for a human study, that's really tiny. We look at 300 patients as being a huge N number, but 300 patients for a human study is a really small N number. And I found it interesting that they would quote that paper. I don't know why, and I guess I need to pull it up and look at it, but they said that 42.9% patients with hyperlactatemia died, only 8 of 103 or 7% without hyperlactatemia died. So they were quoting that paper to talk about survivability with and without hyperlactatemia, but I just thought the number was pretty low for a human study. All right. You did mention the treatment protocols were not standardized, and they included that as one of their limitations in their study. Any other comments on this particular paper? So how are we going to use these the information from these two papers in our practice? We'll get to you in a minute, Cassie. How do you think we ought to take this information, and how should we apply it to our clinical practice, or should we? Right? Because ultimately that's the goal of reading the literature, right? Right. Anybody want to voice an opinion?
I think kind of coupling everything together in lieu of what your patient looks like is probably the best way to go about it. Using your physical exam in conjunction with at least one lactate to get an idea, and then serial lactates going down the line to kind of track your progress. If, from my study, if you have a prospective study of, more standard, we do, X amount of boluses to, get the lactate in a more reasonable level, and then continue to monitor it, I think would be probably the most ideal if we're able to do it. So
that's a fair enough comment. Anybody else have anything to say?
Just a question. So in a previously healthy patient that did not have a compromise prior to this acute event of decreased tissue perfusion, what is the half-life of lactate? So if you're doing serial monitoring, how quickly do you need to take another blood lactate?
It can drop like a rock. I mean, it really can go down really super duper fast. That pyruvate dehydrogenase that shuttles it back and forth from pyruvate to lactate really works very quickly. And we have seen a lot of trauma patients come in that are clearly hypoperfused or in hemorrhagic shock, and we appropriately resuscitate them, take a lactate 30 minutes later, hour later, you can easily see it change very dramatically, very quickly under those circumstances.
Okay.
Yeah. So, Cassie, you and Andrew, and I know Andrew's there, you guys got the great big giant article from the Human Chest Journal on lactic acidosis and sepsis, quote unquote, it's not all anaerobic. And what I asked you to do when I sent that to you was just kind of give us some other ideas of why lactate could be elevated. Hi, Andrew.
Hi.
So which two, we're down to your paper. The other guys can hopefully catch you up on what we decided about the first two. because I know you didn't receive the first two, so maybe you guys can give him a capsule of what we talked about since he was busy working. And we were just now getting to the chest article. And I was saying that the whole purpose of this was not really to go over all of sepsis, but mainly to use it as an indication of other reasons why we can be hyperlactemic, other than decreased tissue oxygen delivery. So who would like to start? Kitty cat. All right. One of the two of you want to just make some comments on other reasons why we can have hyperlactatemia?
I mean, I guess they kind of broke it down into a couple categories. So broadly, just A and B categories. So A relating to hypoxemia, and then B not relating to hypoxemia, and then kind of breaking it down further. So hyperlactemia related to underlying diseases, such as liver failure, but definitely not limited to that, kind of liver failure, sepsis, diabetes, pheochromocytoma, malignancy, kind of a whole category of things. And then B2 was toxins, so a lot of different toxins, either ones that they got into accidentally or even medications that we give. So like epinephrine, terbutaline, and then ethylene glycol, propofol. I mean, there's a kind of a whole list of different drugs either that they got into or that we give them that can cause hyperlactemia. And then kind of their third category was different metabolic problems. So whether they're just kind of, a deficiency from a lot of inborn deficiencies in metabolism, again, kind of things that we don't really see, or I have never really heard of in dogs, but just kind of definitely there, with all of the sepsis, there definitely is an aspect of poor tissue perfusion that's leading to the lactic acidosis, but there's also a primary underlying cause, and we have to treat both of them. And it's not going to completely drop without treating the underlying problem as well.
That's good. Andrew, do you have some additional comments to that?
I'm sorry, me?
Do you have additional comments?
Not particularly. I think that was a good overview. I think it's interesting, to think of the whole picture rather than just decreased perfusion leading to the lactic acid production, but also decreased, substrate, such as the glucose.
Right.
Our hypoglycemic patients, and we're wondering why are they, have a lactic acidosis? Are they also hypovolemic? Well, not always.
Yeah. So that was the whole point of this particular piece of literature, was to get us to look at all the different reasons that a patient could be hyperlactemic. So it seems like in veterinary medicine, and I think as evidenced by the first two papers, that we see an elevated lactate in the patient, we automatically think they have decreased oxygen delivery, right? That's kind of like almost an automatic association. Well, they might be hypoperfused or whatever, but it's really important to recognize that although that's an important cause and often a frequently seen cause, there can be a lot of other reasons that we can be hyperlactemic. For example, lungs are a huge producer of lactate. Okay, lungs as an organ are a huge producer of lactate, and you can have that when you have like ALI or acute respiratory disease, and not even have hypoxemia, but because the lungs are producing a lot of lactate. That's one example. Thiamine deficiency. Thiamine is a required cofactor, and the generation of ATP by oxidative phosphorylation. And if you have thiamine deficient patients, you can have a hyperlactatemia. Liver disease is certainly important, or hepatic dysfunction can be a cause for hyperlactatemia because it's not working well in the Cori cycle. Beta agonism, you mentioned epi and terbutaline and those kinds of things. Patients that come to us in stress have a high catecholamine level, especially cats, their stress response is epinephrine driven, and dogs it's usually cortisol driven. So whenever you get high catecholamines, you stimulate your sodium potassium ATP pump, and you can get a consequent of that, you can get an elevated lactate. Think about animals we put on pressors for hypotension. Think about animals that come to us that are extremely stressed. That can be actually a fairly common cause of a hyperlactatemia in patients. So I really wanted you all to look at this, and the type A and the type B and the different forms, decreased substrate and all of that is still very important, but there can be some very common things going on in our patients that can contribute to that. The other thing that I liked about this particular paper is it discussed where does the quote-unquote acid come from. And I don't know if you noticed that little paragraph, but really when you have the glycolytic pathway is being driven for whatever reason, and you have lactate production, and you have ATP breakdown, it's the hydrogen ions from the ATP breakdown that actually creates your acidosis. Okay, we call it lactic acidosis because there's a high lactate, but the acidosis is actually the protons from the break the ATP. So it's just a little bit more nuanced consideration for terms that we use fairly cavalier when we're discussing some of these patients. So that's the big thing that I wanted you all to take from this. I'm going to send all these papers to everybody. I didn't do that in the beginning, but I'll send all these papers to everybody. And as usual, I have a podcast to send to you all from the Intensive Care Network. This particular podcast is 2014. It talks about the myth of lactic acidosis, and it goes into a little bit more detail about why you can have a hyperlactatemia that's not secondary to hypoperfusion. Okay? And just for your consideration, does anybody else have any other comments? No?